Welcome. With this session, we'll begin our discussion of retinal vascular diseases, and we'll begin with the most important among them, diabetic retinopathy. And in this session, we'll be discussing about the pathophysiology and risk factors of diabetic retinopathy. Globally, 1 in 11 adults have diabetes mellitus, and 90% of diabetes mellitus patients have type 2 diabetes mellitus. Diabetic retinopathy or DR is the leading cause of blindness between 25 to 74 years of age in developed countries. And it is estimated that 1/3 of all diabetics have some form of diabetic retinopathy, and among the latter, 1/3 have a sight-threatening form of diabetic retinopathy. And after 15 years of having diabetes, more than 75% of patients have some form of diabetic retinopathy. Loss of vision in diabetic retinopathy can be due primarily to three reasons. One is macular edema from capillary leakage, as seen here in these zones in this fluorescent angiogram, from macular ischemia resulting from capillary occlusion, as seen in this area in this angiogram, and from sequelae of capillary occlusion such as vitreous hemorrhage, tractional retinal detachment, and neovascular glaucoma. This color photograph shows a patient with tractional retinal detachment nasal to the optic disc, and this may occur temporal to the optic disc also, involving the macula. And neovascularization with its sequelae is caused primarily by extensive peripheral retinal ischemia, as seen here in this angiogram. And these three primary causes of loss of vision in diabetic retinopathy is very important to remember. Loss of pericytes is one of the earliest and most specific sign of DR. This photograph shows a normal retinal capillary with normal pericytes being visible, and in this figure, from a diabetic retinal capillary, their pericytes are absent, and in their place there is vacuolar bumps in the wall of the capillary. Loss of pericytes, as we will be discussing, lead to venous dilatation, microaneurysm formation, and disruption of the inner blood-retina barrier. And the proposed mechanisms of loss of pericytes in hyperglycemia include aldose reductase pathway, which we will be discussing further in this session. Capillary basement membrane thickening is another well-documented feature of diabetic retinopathy, along with deposition of abnormal fibrillar collagen in and Swiss cheese vacuolization of the capillary basement membrane. And proposed mechanisms include aldose reductase pathway and glycation of basement membrane collagen and other components of the basement membrane. Microaneurysm formation is the earliest clinically visible sign of diabetic retinopathy, which are visible as tiny red dots on clinical examination and which typically hyperfluoresce on fluorescent angiography. On light microscopy, they appear as saccular or spindle-shaped dilatations of the retinal capillaries and may be hypercellular or acellular in nature. It is hypothesized that pericyte loss may lead to microaneurysm formation because loss of pericytes lead to proliferation of endothelial cells to form hypercellular microaneurysms. And also, since pericytes are contractile, loss of pericytes lead to structural weakening of the capillary walls, leading to microaneurysm formation. And microaneurysms appear acellular when pericytes and endothelial cells undergo apoptosis. As we have mentioned, breakdown of blood-retinal barrier is one of the three causes of loss of vision in diabetic retinopathy because it leads to macular edema, which is the leading cause of vision loss in diabetes. And among factors which may promote breakdown of blood-retinal barrier is VEGF, which is the most commonly targeted molecule in current therapy of diabetic macular edema. As we have mentioned, capillary ischemia is another cause of vision loss in diabetic retinopathy, both when it involves the foveal region itself as well as when there is extensive peripheral retinal capillary occlusion leading to neovascularization. And capillary ischemia in diabetic retinopathy may occur due to occlusion of capillaries because of low-grade inflammation leading to increased activation of leukocytes with increased adherence of these cells to the capillary walls, as well as platelet abnormalities which are known to occur in diabetes mellitus. The other cause of ischemia is loss of all cellular elements of retinal capillaries, which is called capillary acellularity. Neovascularization and its sequelae is another cause of loss of vision in diabetic retinopathy, as we have mentioned, and neovascularization occurs due to extensive retinal capillary ischemia leading to hypoxia of these retinal areas, and in these hypoxic zones of retinal ischemia there is suppression of destruction by ubiquitination of hypoxia inducible factor 1 alpha, resulting in increased levels of this factor, which is a promoter of VEGF gene, thus increasing the production of VEGF. VEGF then attaches to endothelial cells and promotes endothelial cell proliferation to form new vessels. So it is important to note that VEGF is responsible for both breakdown of inner blood retinal barrier and neovascularization, which are important causes of loss of vision, and it is also hypothesized that neuropathy due to diabetes involves retinal layers, leading to the observation of thinning of inner retinal layers even before clinically detectable microvascular lesions appear. Chronic hyperglycemia is known to cause all the vascular changes of diabetic retinopathy, and the biochemical pathways are still unclear, but the following mechanisms have been proposed. In the aldose reductase pathway, increase in intracellular levels of glucose due to chronic hyperglycemia stimulates aldose reductase, but the stimulation of aldose reductase occurs only when all other pathways of glucose utilization within the cell has been saturated. Aldose reductase then reduces glucose to sorbitol, following which sorbitol dehydrogenase oxidizes sorbitol to fructose. Sorbitol dehydrogenase is a slowly acting enzyme, so sorbitol accumulates within the cell. The aldose reductase pathway may cause damage by following mechanisms. Sorbitol does not easily cross through the plasma membrane into the extracellular space, and accumulation of sorbitol may produce osmotic stress, and the changes of redox balance within the cell because of this pathway may lead to decline in nitric oxide production, with nitric oxide being a vasodilator and oxidative stress. But treatment with sorbinil, which is an aldose reductase inhibitor, has not been shown to reduce worsening of diabetic retinopathy. In the advanced glycation end product pathway, hyperglycemia causes non-enzymatic glycation of various molecules, particularly proteins, both in the intracellular as well as the extracellular space. The initial glycation product undergoes rearrangement followed by several reactions to form the final irreversible advanced glycation end product, and these AGEs then can undergo further cross-linking. Glycation can cause direct inactivation of proteins, but in addition, advanced glycation end products may activate their own transmembrane cellular receptors called RAGE, which may activate various intracellular kinases, which can lead to cellular dysfunction. Aminoguanidine, which prevents the formation of AGEs, has been shown to prevent various complications of diabetic retinopathy in animal experiments, but clinical trials have been inconclusive because of dose-limiting toxicity of this drug. The photoreceptor metabolism theory of diabetic retinopathy states that in the dark adapted state, rods consume high levels of oxygen, creating relative hypoxia in the retinal environment, and this, when coupled with pseudohypoxia of hyperglycemia, promotes VEGF production. And pseudohypoxia of hyperglycemia occurs because of altered cellular redox balance, which we have discussed. And panretinal photocoagulation and supplemental oxygen therapy have been shown to reduce progression of DR by reducing tissue hypoxia. Hyperglycemia increases the generation of reactive oxygen intermediates, particularly superoxide anions, which are produced as byproducts of oxidative phosphorylation pathway, and otherwise can have multiple deleterious effects such as damage of cellular proteins and mitochondrial DNA, increased adhesion of leukocytes to blood vessel walls, increased leakage through blood-retina barrier, reduction in nitric oxide levels, and activation of protein kinase C. The protein kinase C pathway is stimulated by diacylglycerol, and hyperglycemia can lead to increased production of diacylglycerol. Activation of protein kinase C can subsequently activate various intracellular kinases, which may lead to increased vascular permeability, increased addition of leukocytes to endothelium, disruption of nitric oxide metabolism, and increased production of VEGF. Advanced glycation end products, reactive oxygen intermediates, VEGF, and endothelin can also activate protein kinase C. but reboxystorin, a protein kinase C inhibitor, has not yet shown statistically significant beneficial effects on diabetic retinopathy in clinical trials. Also, in individuals whose photoreceptors express increased levels of retinol binding protein 3 have a reduced risk of diabetic retinopathy and its progression, because retinol binding protein 3 binds to glucose transporter 1, which is the major transporter of glucose into the endothelial cells. Among the risk factors of diabetic retinopathy, duration of diabetes mellitus is the most important, and this cannot be overemphasized and is very important to remember. The Wisconsin Epidemiologic Study of Diabetic Retinopathy, or WESDR, which was a cross-sectional study and not a longitudinal study, found that among patients with type 1 diabetes mellitus, in patients who had more than 5 years of diabetes mellitus, 13% had some form of diabetic retinopathy, and this figure increased to 90% in patients who had diabetes mellitus for more than 10 to 15 years. And among patients who had diabetes mellitus for more than 15 years, 25% had proliferative diabetic retinopathy. Among patients with type 2 diabetes mellitus who were on oral hypoglycemic agent at the time of evaluation, the WSDR found that among patients who had diabetes mellitus for more than 5 years, 24% had some form of diabetic retinopathy, but this increased to 53% among patients who had diabetes mellitus for 15 to 19 years. And among patients who had type 2 diabetes mellitus but were on insulin at the time of evaluation, 40% of patients who had diabetes mellitus for more than 5 years had some form of diabetic retinopathy, which increased to 84% in patients who had diabetes mellitus for more than 15 to 19 years. Also, the WESDR found that among patients who had diabetes mellitus for 5 years, 2% had proliferative diabetic retinopathy, and this figure increased to 25% among patients who had diabetes mellitus for more than 25 years. But there were two caveats of WESDR. One was it largely included participants of Northern European descent, and so its results may not be applicable to other races. And second, unlike WESDR, which was conducted in the early 1980s, more recent reports suggest that rates of diabetic retinopathy progression and vision loss have decreased with improvement in systemic metabolic control and ocular treatment of diabetic retinopathy. And the duration of diabetes after the onset of puberty appears to be the most important risk factor of diabetic retinopathy. As we have seen in WESDR, proliferative diabetic retinopathy is more prevalent in type 1 diabetes mellitus patients as compared to type 2 diabetes mellitus patients of equal duration, but diabetic macular edema occurs with similar frequency in type 1 and type 2 diabetes mellitus of equal durations. And since 90% of diabetes mellitus patients have type 2 diabetes mellitus, proliferative diabetic retinopathy and diabetic macular edema more frequently presents in the clinic in patients with type 2 diabetes mellitus. And importantly, presence of diabetic retinopathy at diagnosis of diabetes mellitus is more common in type 2 diabetes mellitus as compared to type 1 diabetes mellitus, and this is very important to remember. So newly diagnosed patients with type 2 diabetes mellitus should ideally undergo a retinal evaluation immediately following their diagnosis of diabetes mellitus. Apart from duration and type of diabetes mellitus, hyperglycemia, hypertension, and hyperlipidemia are the major risk factors of diabetic retinopathy. The DCCT was designed to assess the efficacy of control of hyperglycemia in preventing the complications of diabetes mellitus in patients with type 1 diabetes mellitus. The DCCT randomized type 1 diabetes mellitus patients into conventional and intensive insulin treatment groups. The intensive insulin treatment group received 3 or more daily injections of insulin or insulin pump therapy guided by self-monitored glucose level testing 3 to 4 times daily to achieve near normal blood glucose and HbA1c levels. And the conventional insulin treatment group monitored blood glucose levels once per day. The DCCT found that in those without retinopathy at baseline, there was 75% reduction in risk of developing retinopathy in intensive treatment group as compared to the conventional treatment group, at 3 years of the study, and among those with retinopathy at baseline, there was 50% reduction in risk of progression of retinopathy in the intensive treatment group as compared to the conventional treatment group at 3 years of the study. But at 6 to 12 months from baseline, there was a slight worsening of retinopathy with intensive treatment, which was unlikely to threaten vision. And for every step of decrease in HbA1c, there was a predictable decrease in risk of retinopathy progression. The DCCT also found a statistically significant reduction of nephropathy and peripheral neuropathy in the intensive treatment group as compared to the conventional treatment group. The EDIC study was a follow-up study to DCCT in which DCCT participants were given an additional 7 years of insulin therapy, and during these additional 7 years, 69% of those in the original conventional treatment group received intensive insulin treatment. The EDIC study found that retinopathy progression remained lower in participants who were in the original intensive treatment group in the initial 6.5 years of DCCT as compared to those who were in the conventional treatment group in the initial 6.5 years of DCCT. The UKPDS, or the United Kingdom Prospective Diabetes Study, randomized newly diagnosed type 2 DM patients into conventional therapy group and an intensive therapy group. The conventional therapy group had a target fasting blood sugar of less than 270 mg per deciliter, and in the intensive therapy group, the target FBS was less than 106 mg per deciliter. After 12 years of UKPDS study, the rate of retinopathy progression reduced by 21% in intensive treatment group as compared to patients in the conventional treatment group. Need for laser photocoagulation was also reduced by 29% in the intensive treatment group as compared to the conventional treatment group. And for UKPDS also, for every step decrease in HbA1c, there was a predictable decline in microvascular complications of diabetes. The ACCORD trial randomized type 2 DM patients into a standard treatment group in whom target HbA1c was between 7% and 7.9%, and an intensive treatment group in whom the target HbA1c was below 6%. Among a total of 10 to 51 participants, ophthalmic evaluations were done in 2856 participants for 4 years. At 4 years, the ACCORD trial found that the rate of retinopathy progression was 7.3% in the intensive treatment group as compared to 10.4% in the standard treatment group. The ACCORD trial was prematurely halted at 3.7 years because of increased incidence of all-cause mortality in the intensive treatment group. The effect of control of hypertension on diabetic retinopathy in type 2 DM patients was also evaluated by the UKPDS and ACCORD trials. The UKPDS randomized type 2 DM patients with hypertension into a more intensive blood pressure control group in whom the target systolic blood pressure was less than 150 millimeters of mercury, and a less intensive blood pressure control group in whom the target systolic blood pressure was less than 180 millimeters of mercury. And after a median follow-up of 8.4 years, UKPDS found a 37% reduction in the risk of microvascular complications of diabetes mellitus, predominantly a reduced risk for laser photocoagulation in the more intensive blood pressure control group as compared to the less intensive blood pressure control group, but there was no significant difference between intensive blood pressure control with either beta blockers or ACE inhibitors. The ACCORD trial randomized type 2 DM patients with hypertension into an intensive blood pressure control group targeting systolic blood pressure less than 120 millimeters of mercury, and a standard blood pressure control group targeting systolic blood pressure less than 140 millimeters of mercury. And at 4 years, the ACCORD trial found that the rates of retinopathy progression were not significantly different between the two groups. The UKPDS and ACCORD results on the efficacy of control of hypertension on diabetic retinopathy are not necessarily contradictory because of the different target blood pressures used in the two studies. Elevated levels of serum cholesterol was associated with increased severity of retinal hard exudates in WESDR and ETDRS. We'll be discussing about ETDRS in the next session on non-proliferative diabetic retinopathy. This color photograph shows a surge synchrotron of hard exudates. The ETDRS also found that presence of retinal hard exudates is associated with decreased visual acuity independent of any associated macular edema, and also elevated plasma triglycerides are associated with an increased risk of developing high-risk PDR. The ACCORD and the field trials found that phenylfibrates reduce the progression of diabetic retinopathy, although the effect of phenylfibrate on plasma lipid profile is modest. Other systemic risk factors which have been found to affect the course of diabetic retinopathy include diabetic nephropathy, anemia, severe carotid occlusive disease, which we will be discussing further in the session on ocular ischemic syndrome, and pregnancy. And in pregnancy, among those without retinopathy at onset of pregnancy, 10% developed some form of diabetic retinopathy during pregnancy, and among those with NPDR at onset of pregnancy, 4% developed proliferative diabetic retinopathy. And it has also been found that pregnancy, particularly with hypertension, worsens both existing NPDR and PDR. Anti-diabetic drugs have also been found to affect the course of diabetic retinopathy, and it is well known that very intensive therapy with insulin temporarily worsens diabetic retinopathy. And other anti-diabetic drugs have also been found to have an effect on progression of DR. Three ocular factors are known to reduce the prevalence and severity of diabetic retinopathy, namely glaucoma, myopia, and extensive chorioretinal scarring, and these are important to remember. That genetics play a role in the development of diabetic retinopathy in patients with diabetes mellitus was suggested by the finding of diabetic retinopathy study that only 50% of patients with non-proliferative diabetic retinopathy progress to proliferative diabetic retinopathy, and many patients with diabetes mellitus never develop diabetic retinopathy. The DCCT also found familial clustering of severe diabetic retinopathy. It has also been found that individuals who express both HLA-DR4 and HLA-DR3, the primary HLA antigens associated with type 1 diabetes mellitus, have a significantly increased risk of proliferative diabetic retinopathy. Candidate gene approaches have identified single nucleotide polymorphisms in several genes such as VEGF, receptor for advanced glycation end product, erythropoietin, and T-selectin to be associated with diabetic retinopathy. Genome-wide association studies has not shown any polymorphisms to be consistently associated with the development of diabetic retinopathy, and whole exome sequencing studies have shown variants of several genes to be either protective against diabetic retinopathy or to be associated with the risk of development of proliferative diabetic retinopathy. And variations in the pathways of epigenetic regulation of gene expression have also been found to be associated with the risk of or protective against the development of diabetic retinopathy. Three clinical forms of diabetic retinopathy have been described: non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and diabetic macular edema. Non-proliferative diabetic retinopathy, which we will be discussing in the next session, is defined as the presence of only intraretinal microvascular alterations and is classified into mild, moderate, and severe non-proliferative diabetic retinopathy or NPDR. And proliferative diabetic retinopathy or PDR is defined as the development of extraretinal neovascularization due to diabetes-induced retinal ischemia. Eyes labeled as having proliferative diabetic retinopathy by this definition may have associated NPDR changes, and PDR is classified into early stage PDR and PDR with high risk characteristics, which we will be discussing in the session after next. Diabetic macular edema is the thickening of macula due to vascular hyperpermeability and can occur in any stage of either NPDR or PDR. Current classification of diabetic macular edema is based on optical coherence tomography and includes two forms: center involved diabetic macular edema and non-center involved diabetic macular edema. Center involving diabetic macular edema is defined as thickening of the central 1 mm subfield of retina on optical coherence tomography, and non-center involved diabetic macular edema is defined as presence of thickening of the retina outside the central 1 mm subfield on optical coherence tomography. Previous description of clinically significant macular edema or CSME is no longer used for deciding treatment of diabetic macular edema. To recap the salient points, diabetic retinopathy is the leading cause of blindness between 24 and 75 years of age in developed countries. Loss of vision in diabetic retinopathy can be due to macular edema, macular ischemia, and sequelae of neovascularization such as vitreous hemorrhage, tractional retinal detachment, and neovascular glaucoma. Characteristic pathologic changes in diabetic retinopathy include loss of pericytes, microaneurysm formation, thickening of capillary basement membrane, disruption of inner blood-retina barrier, capillary ischemia, and neovascularization. VEGF produced by ischemic retina can induce both disruption of the inner blood-retina barrier and neovascularization. Biochemical pathways which may be involved in the pathogenesis of diabetic retinopathy are aldose reductase pathway, advanced glycation end product pathway, protein kinase C pathway, reactive oxygen intermediates, and photoreceptor metabolism induced hypoxia. Risk factors of diabetic retinopathy include duration and type of diabetes mellitus, hyperglycemia, hypertension, dyslipidemia, diabetic nephropathy, anemia, pregnancy, and genetic factors. And these are the landmark clinical studies identifying these risk factors. Eyes with myopia, glaucoma, and chorioretinal scarring have reduced prevalence and severity of diabetic retinopathy. Thank you for listening.